Hello, everyone. Today, my group, Soyun, Marilyn, Jacob, Sarah, and me, Javier, are going to be presenting the topic hiatal hernia. For the etiology of a hiatal hernia, it's not very well understood what the exact cause is. A hiatal hernia is an anatomical deformity believed to be related to conditions that increase intra-abdominal pressure or loosening of the connective tissue. For the definition, a hiatal hernia is a condition in which the upper part of the stomach or other internal organs bulge through the hiatus of the diaphragm. As you can see in the picture, we have a normal upper digestive tract next to a hiatal hernia. The lower esophagus is bulging past the diaphragm, causing the hiatal hernia. For risk factors, we have conditions that increase intra abdominal pressure. This would be ascites, pregnancy, obesity, conditions that cause chronic straining, such as lifting heavy objects, constipation, vomiting, coughing, chronic obstructive pulmonary disorder. Other risk factors include trauma, so injury to the diaphragm from a fall or traffic accident. Another risk factor would be age. It's usually found in older adults due to muscle weakness and loss of flexibility and elasticity as we age. Surgery is another risk factor. Skeletal deformities as well, scoliosis and kyphoptosis can cause distortions of the anatomy of the diaphragm. Congenital diaphragmatic hernia is another risk factor. This is synonymous to hiatal hernia. For the epidemiology, we have age. The incidence of hiatal hernias increase with age. An estimated 55 to 60% of adults over the age of 50 have a hiatal hernia, although only 9% of the cases experience any sort of symptom. For gender, we have the prevalence of hiatal hernias being higher among women compared to men. This can be attributed to pregnancy causing an increase of intra-abdominal pressure. It occurs in roughly 15 to 20% of pregnant women. It's also the most likely hernia to happen in pregnant women. The majority of hiatal hernias are type 1 sliding, with type 2 being less than 5% of the total cases. That would be it for epidemiology.
Hi, my name is Amy, and from this presentation, my part is pathogenesis and then introduction of case study and situation of the hiatal hernia. For the pathogenesis, a hiatal hernia is a defect in the diaphragm that allows a portion of the stomach to pass through the diaphragmatic opening into the thorax. There's two main types. Type 1 is a sliding hiatus hernia. In this case, part of esophagus and then esophagus gastric junction protrude above the diaphragm, and it is the most common case. And in this case, there is no symptom and only mild symptom at the first time, but the symptom of GERD, gastrointestinal reflux disease, may appear over the time. Type 2 is a paraesophageal hernia. In this case, only the stomach, not the esophagus, only the part of stomach protrude above diaphragm and move up to the side of the esophagus. In this case, the part of the raised stomach is trapped by diaphragm, so making it difficult to supply blood and problem may become serious. There is also type 3. In type 3, the mixed feature of type 1 sliding hiatus hernia and then the paraesophageal hernia may occur together. So main symptom is the heartburn may occur as the gastric juice reflux into the esophagus and difficulty swallowing the food, chest pain, bloating, and internal bleeding may result in vomiting the blood or black stool may occur. For the case study and situation, a 79 years old male patient was admitted to the hospital with dysphagia and then body weight loss. Patient has been having severe dysphagia and body weight loss of 10 kg for past 3 months. To find out the reason for the dysphagia and body weight loss, some several tests or examination is performed, and delayed barium passage was observed on the upper gastrointestinal examination. That means the blockage. And esophagitis and tumor in the upper digestive tract were not found from the endoscopic examination. And a large hiatal hernia involving entire stomach was found from the enhanced compute tomography.
Hi, my name is Marilyn, and I will first be going over the background for our case study. So our patient has a history of distal gastrectomy for a submucosal benign tumor 40 years prior. A distal gastrectomy consists of the surgical removal of the distal third of the stomach. This procedure was an open surgery without lymph node dissection, and it had a Billy-Roth 1 reconstruction. The patient was noted to also have a bent-over posture due to osteoporosis. No other medical or family history was provided for this particular case study. Now, for common clinical manifestation of hiatal hernia, so for small cases of hiatal hernia, patients are mostly asymptomatic. Most of the time, providers find that the patient has hiatal hernia while doing a procedure like an upper endoscopy for a different condition. So, but then for large hiatal hernias, there can be symptoms such as acid reflux, so acid moving back up the esophagus. This can cause feelings like heartburn, discomfort, burning sensation in the mid-chest. There can also be regurgitation of food back up to the mouth. Patient can also have this bitter taste in their mouth. And there's also difficulty swallowing, dysphagia, bloating, belching, abdominal pain, chest pain, feeling of fullness soon after eating, and also shortness of breath. For more serious cases like the abdominal pain and the chest pain, and also vomiting up blood or blood in the stool, it does require immediate medical attention. So for our particular case study, the patient we want to repeat is the 79-year-old male patient that was referred to the hospital for difficulty swallowing and weight loss of 10 kilograms over 3 months. Now, upon admission, the patient had a height of 158 centimeters, a weight of 53.6 kilograms, and a BMI of 21.5. Some of the tests that were done is an upper endoscopy. It showed that the post-operative stomach is now in the thoracic cavity. The endoscopy also showed that there's no inflammation of the esophagus and there's no tumor in the upper digestive tract. An enhanced CT was also done. It shows that the hiatal hernia is of the entire stomach. It's a combined type. So a hiatal hernia of the entire stomach is a pretty rare circumstance for this particular condition. And the stomach was also seen to be expanded with food. Now, the stomach's position in the posterior mediastinum actually puts a bit of pressure and compresses the heart, but an echocardiogram was done and it showed normal heart function and no cardiac failure. We also want to note that the esophageal hiatus is 7 centimeters in diameter.
Hello, my name is Jacob Soto. Today I'm going to be doing my presentation on hiatal hernia. My presentation consists of diagnosis and assessments. To begin, hiatal hernia is observed during a test procedure to determine the cause of heartburn or chest or upper abdominal pain. These tests or procedures include a computerized tomography, which is abbreviated CT. Scans combines a series of X-ray images taken from different angles around your body and uses computer processing to create cross-sectional image slices of the bone, blood vessels, and soft tissues inside your body. CT scans images provide more detailed information than X-rays do. Next up, we have X-rays of your upper digestive system. X-rays are taken after you drink a chalky liquid that coats and fills the inside lining of your digestive tract. The coating allows your doctor to see a silhouette of your esophagus, stomach, and upper intestines. Next up, we have upper endoscopy. Your doctor inserts a thin, flexible tube equipment with a light and camera which is an endoscope, down your throat to examine the inside of your esophagus and stomach and check for inflammation. And finally, we have an esophageal manometry. This test measures the rhythmic muscle contractions in your esophagus when you swallow. The esophageal manometry also measures the coordination and force exerted by your muscles in the esophagus. Next up, we have assessments. In our case assessment, we found that the endoscopic examination showed that the esophagitis and tumor in the upper digestive tract were absent. Enhanced computerized tomography, abbreviated ECT, revealed a large hiatal hernia involving the entire stomach, sliding through the hiatal orifice into the mediastinum, and that the stomach was expanded with food remaining inside. The stomach in the posterior mediastinum compressed the heart. However, the patient had no sign or symptoms of cardiac failure, and the heart function was normal on the echocardiograph. Finally, preoperative ECT scans also showed that the right and left gastric arteries and the gastroepiploic arteries were preserved, indicating that the distal gastrectomy had been performed without lymph node dissection. Thank you and that was my presentation.
Clinical management and treatment of hiatal hernia. We can give the patient proton pump inhibitors, which is going to decrease the gastric acidic secretions within the stomach. It'll relieve the heartburn subsequently, and then we can counsel the patient. The patient should avoid smoking, triggering foods, and alcohol. The patient should have smaller, frequent meals as to avoid overfilling the stomach. Surgical repair for large hernias or paraesophageal hernias can also be done. We have the Nissen fundoplication, which is where we're going to take that stomach, wrap it all the way around the esophagus to put pressure on the LES. We can do the door procedure, which is where we're going to take the stomach, wrap it around the front of the esophagus, or we could do the tourpe, which is going to take the stomach, wrap it around the back of the esophagus. Recommendation are a VESPAR. Considering the patient's hernia involves the entire stomach and that the inpatient is experiencing both dysphagia and weight loss, a Nissen fundoplication is recommended, which is again where we're going to take that stomach, wrap it around the esophagus to put pressure on the LES, allowing it to close. Proton pump inhibitors are also recommended in order to decrease the acidic secretions within the patient's stomach. Future application as nurses. As a future nurse, this information can be applied in the scenario of a patient possibly presenting with a hiatal hernia. We're going to look at their signs and symptoms, and we may see heartburn, chest pain, dysphagia. We're going to look at their history. We're going to look at their risk factors, increasing age and elevated intra-abdominal pressure. This elevated intra-abdominal pressure might be attributed to things like pregnancy, obesity, COPD, all things that are going to put more pressure inside on that stomach. If diagnosed, we have a few treatment options. We're going to counsel the patient on what lifestyle changes to make, such as avoiding triggering foods, avoiding smoking, avoiding alcohol. We're going to have the patient take proton pump inhibitors in order to decrease the gastric secretions within the stomach. And we're going to potentially do a Nissen fundoplication. Again, Nissen fundoplication is where we take the stomach, wrap it around the esophagus to put pressure on the LES in order to decrease the gastric secretions going up into the esophagus, causing that heartburn. And here are our references. Thank you very, very much.